Well, welcome back. In this session, we're going to be looking at lung disease caused by environmental factors in the workplace. Sometimes these are referred to as occupational or industrial lung diseases. And in addition, we're going to look briefly at other diseases, including neoplastic and infectious diseases. As it turns out, these are not particularly important in the area of pulmonary pathophysiology, which is what these lectures are about, but they are extremely important in the general context of pulmonary medicine and pulmonary pathology, and so we'll deal with them briefly. Now first, I thought we should look at the normal atmospheric pollution factors, and here I should say that I dealt with those to some extent in the companion series on respiratory physiology under the heading of defense systems of the lung, and so I'm going to just review those rather briefly. So here we've got the types and sources of atmospheric pollutants that we're all exposed to. And you can see that the major pollutant by weight in the atmosphere is carbon monoxide. And of course that's important because it ties up hemoglobin. It's got a very high affinity for hemoglobin, and it ties some of it up so it's not available for oxygen transport. And in addition, it causes the oxygen dissociation curve to shift to the left. It increases the oxygen affinity of hemoglobin, and that leads to problems with unloading the oxygen in the periphery. Next, we've got the oxides of sulfur and nitrogen. These are important because when they dissolve in water, they form acids, which are injurious to mucous membranes and the lining of the airways. The sulfur in sulfur oxides comes from the sulfur in the oil that's burned, and the nitrogen oxides come from the combustion of fuels at very high temperatures. There are also hydrocarbons, but these are not particularly important, except as we'll see later in the generation of smog. Now the sources of these pollutants, as you can see, most of them actually come from transportation. And I'm sorry to say that many of them come from our own automobiles. So we are responsible for a substantial amount of these pollutants, although the catalytic converters certainly help. The other major source are the power plants, stationary power plants, and industrial processes. Now, one of the pollutants not mentioned there, but very important, are the photochemical oxidants. Now, those are formed when hydrocarbons and nitrogen oxides are acted upon by sunlight, high activity, and in a slow reaction, they result in a number of very unpleasant substances, including ozone, peroxyacyl nitrate, aldehydes, acrolein, and so on. And these are the components of smog. Now this reaction is slow, so that typically what happens if a tanker is unloaded, say in Long Beach in Southern California, and the winds, the prevailing westerly winds, move the material to the east, there's a slow reaction which generates these smog components. And so the smog is mainly seen a number of miles inland. These photochemical oxidants are toxic. They harm people, cause inflammation of the upper respiratory tract. They harm plants. They have offensive odors, and that's what we know as smog. The existence of smog, the intensity is increased if you have a low-lying area surrounded by hills, as for example in the Los Angeles basin, and you can get a temperature inversion there where the normal escape of materials to the atmosphere is prevented. Let's now look at the most important pollutant by far, which of course is smoking. Smoking is responsible for an enormous amount of morbidity and mortality, and you'll notice that the CDC makes the statement that cigarette smoking continues to be the leading cause of preventable morbidity and mortality in the United States. So smokers, of course, inhale pollutants in far higher concentrations than you do in a polluted atmosphere, and smoking causes many diseases, including bronchial carcinoma, COPD, coronary artery disease, and it's an obligation for all of us, I think, to try and reduce this terrible scourge. Now let's look at the behavior of aerosols in the lung, because these pollutants exist as aerosols. An aerosol is a cloud of small particles that remain suspended for a very long time because of convective effects. And we're going to look first at the deposition of pollutants in the lung and then their clearance. And the deposition is nicely shown in these three cartoons here. The larger particles, say larger than 5 microns or so in size, largely deposit by what's called impaction. As the particles are inhaled, they have to turn sharp corners and they run off the road, as it were, like a sports car going around a corner too fast, and they impact on the moist mucous membranes. They're then trapped and they're removed from the system that way, and that's very important in the nasopharynx. The next important mechanism is sedimentation, which refers to the gradual settling of particles as a result of gravity, and that's particularly important in the small airways, partly because the distance that they have to fall is rather small, and that affects the medium-sized particles, say 1 to 5 microns particularly. And then finally, we've got the very small particles, say less than 0.1 of a micron in diameter, and these have a certain amount of diffusion, although it's still quite slow, but nevertheless some of them can reach the alveoli through diffusion. So you've got these three different mechanisms of deposition. Now, we've referred to the sedimentation before of particles in the small airways of the lung, and I'll refer to it again because it's so important. And the point here is that inspired gas can get to the terminal bronchioles, respiratory bronchioles by normal convective flow, but beyond that the gas moves predominantly by diffusion. However, the particles cannot do this because they are too massive to diffuse, and so they tend to sediment in the region of the terminal bronchioles and respiratory bronchioles. And here's a very graphic representation of that. It's a coal miner's lung, and you can see the location of the dust is in the region of the terminal respiratory bronchioles in the center of the acinus, and that the peripheral alveoli, which are around here, are completely spared. And this is shown in a cartoon at the top here. So this, we believe, is an important cause of chronic bronchitis. Early changes in chronic bronchitis occur in the small airways, and that's a very important pathophysiological factor. Okay, let's look at the clearance of deposited particles. And there are two quite different systems. There's a mucociliary system, which operates in the airways, and the alveolar macrophages, which are important in the alveoli. And here's a nice cartoon of the mucociliary escalator. The mucus comes from mucus glands deep in the airway wall with a duct that leads the mucus to the surface. There are also goblet cells in the airway epithelium here. And the mucus consists of two layers. There's a superficial gel layer, which is very sticky, viscid, and traps the particles, and they can't get off once they're trapped. And then there's a lower sol layer, which is less viscous, and in the sol layer, the cilia beat, and the tips of the cilia just touch the superficial gel layer and move it along. And you can see that this is a very elegant system, and you can also see that it takes a lot of regulating. We don't fully understand how it is regulated, but you see it's very important that this sol layer is just the right thickness that the cilia can beat and touch the gel layer above it. And in diseases like chronic bronchitis, where there's an enormous increase in the amount of secretions, the amount of mucus produced in response to the cigarette smoke or whatever that's inhaled, under conditions like that, the characteristics and the amount of mucus are changed, and the mucociliary escalator doesn't work properly at all. Here's a nice electron micrograph showing the tips of the cilia. Here are the cilia here, it's the epithelium here, and here is the gel layer, and the tips of the cilia are just touching the gel layer. And you can see how critical it is that this system maintains the correct thicknesses of these various things. Over here is a cell that may be a goblet cell, I'm not sure. Now in the alveoli, there's no mucociliary system, but instead we have the alveolar macrophages, which roam around the surface of the alveoli by amoeboid action, and they engulf foreign particles, bacteria, any pollutants that happen to get to the alveoli, and once they're engulfed, the macrophages take them away. You can see, by the way, here, beautiful scanning electron micrograph, the macrophage here, and some type 2 cells here with their microvilli. Very nice. Now, here's a nice micrograph, electron micrograph. We've actually seen this before, and this shows an alveolar macrophage in an alveolus, and here's the wall of the alveolus going along here. So the alveolar macrophage is lurking in the corner of an alveolus, and you can see that it has engulfed some foreign particles, and these are remnants of surfactant. You can always recognize surfactant by its sort of onion skin appearance, and surfactant, as we've discussed previously, is turned over rapidly, and the remnants of it have to be picked up, and here's an alveolar macrophage with its nucleus here doing its job. Okay, so that's all I'm going to say about the normal pollutants in the atmosphere. We're now going to turn to these occupational or industrial lung diseases, and we're going to look at 5 of these. Coal workers' pneumoconiosis, sometimes called black lung disease, silicosis, asbestos-related diseases, which have become extremely important recently, Bisson OSIS, caused by cotton materials, and occupational asthma. So let's start with coal workers' pneumoconiosis, which for many years was a tremendous problem, but now is less so because coal dust is controlled in the mines, and it's coal dust that's responsible for the disease. And there are 2 forms of coal workers' pneumoconiosis. One is simple pneumoconiosis, which I'll talk about now, and there is a much more serious problem. Sometimes people develop what's called progressive massive fibrosis. So we saw this image just a little while ago, but it's nice to introduce simple pneumoconiosis, coal workers' pneumoconiosis, because this is exactly what it is. The pneumoconiosis is caused by the deposition of coal dust in the center of the acinus here, as you can see. And as we said before, that's because the coal dust can't diffuse in the gas phase to the periphery. The peripheral alveoli are spared. But in simple pneumoconiosis, what you see in the lung, this is a nice lung slice, and you can see these multiple dots, black dots, throughout the lung here. And these are the little deposits of coal dust that we looked at before. And you can see this on a chest radiograph, although not very easily, but there's a very fine mottling of the radiograph here, which is typical of what we call simple pneumoconiosis. Now, the clinical features of simple coal workers' pneumoconiosis are shown here. Apparently, it causes relatively little change in pulmonary function. Coal dust is relatively inert. It doesn't provoke a reaction in the lung, as we'll see, for example, in silicosis, which we talk about next time, but it's a relatively inert material. Some patients develop a cough, and they have some dyspnea on exertion, and if you do pulmonary function tests, they have a small fall in their forced expiratory volume. But the problem, a common problem, is that many of these miners, patients, are smokers. And many of them have some degree of COPD, and of course COPD causes a cough and mild dyspnea on exertion and a small fall in the FEV. So it's often difficult to know the relative importance of the pneumoconiosis on the one hand and the COPD on the other. And you can see that this raises big problems in workers' compensation, Because if you're a miner and you've been working for 40 years at the coalface, very hard work at unpleasant, difficult conditions, and then later on you become short of breath and you can't walk as far as you could before, and furthermore you have changes seen by X-ray in your lung, then very reasonably you would say, I need workers' compensation. So it's a difficult problem, and I won't say any more about it, but it's one of the difficult problems in compensation work. Now, a few miners go on to develop what's called progressive massive fibrosis, and this is a completely different cup of tea. Here you've got extensive pathology in the lung with areas of dense fibrous tissue, and that's surrounded by areas of lung destruction, surrounded by areas of emphysema. It causes, as you might expect, a major impairment of pulmonary function with marked shortness of breath, reduced exercise capacity, and the pulmonary function tests actually show a mixed obstructive and restrictive pattern. So it's a very serious disease, and fortunately only occurs in a minority of the mine workers who develop pneumoconiosis. Here's an example of a thin lung section in progressive massive fibrosis, and looks awful, doesn't it? Here you've got these big sort of concentrated areas of fibrosis here, and around them you've got these areas of lung destruction, some areas of emphysema. See that down here in the base as well. And look at this radiograph. It just looks awful, doesn't it? Here's an enormous amount of fibrosis around the hilum here, and over-penetrated emphysematous looking lung around it. So progressive massive fibrosis is a very disabling disease indeed, but fortunately occurs only in a minority of coal workers who develop pneumoconiosis. Now let's move to the next pneumoconiosis, and that is silicosis. Now silicosis, in contrast, silica I should say, silica is silicon dioxide, okay, sand. Silica, unlike coal dust, provokes an intense pathological reaction in the lung, big fibrous reaction in the lung, whereas coal dust is relatively inert. Silica is very toxic. And so the silica particles are highly toxic. In fact, if the silica particles are picked up by macrophages, which they are, often they kill the macrophages because the material is so toxic. They cause these whorls of dense fibrous tissue, and I'll show you an example of that in a moment. Mild disease shows a few radiological changes, but not much in the way of symptoms. But advanced disease causes cough and severe dyspnea, and you can actually get progressive massive fibrosis in advanced cases. Here's a beautiful image of a silicotic nodule in the lung. Look at these tremendous whorls of dense fibrous tissue provoked by the silica. I mean, it's obviously a highly toxic reaction that's occurred. The pulmonary function in silicosis is that it causes a generalized diffuse interstitial fibrosis. So it's very like the diffuse interstitial fibrosis that we discussed a couple of sessions ago in the session devoted to restrictive lung disease. You get the typical restrictive pattern, severe dyspnea, hypoxemia, and a reduced diffusing capacity, which is typical of patients who have diffuse interstitial pulmonary fibrosis. So silicosis is a very important disease. The way you prevent it is by using protective equipment. And here's a very nice example of somebody who's using sandblasting. That's a very common cause of use of silica is in sandblasting to clean steel or whatever in an industrial setting. And you can see this man is completely isolated from the silica around him. He's got a hood, the air is being pushed in through a tube here, and so he's protected. But unfortunately, particularly in underdeveloped countries, this is not done. And in fact, just the other day I was reading about the problem that they have in some countries where apparently they sandblast jeans that you wear. Apparently that makes them better for some reason. The people who were sandblasting the jeans developed silicosis, and that of course is tragic when that happens. So it's one of these industrial diseases where controls are extremely important. Now let's turn to asbestos-related diseases, and these have been in the news recently, and actually for a number of years. Up until, I don't know, 50 years ago, people used asbestos extensively, but over recently it's been realized that it's a highly dangerous substance. Here's a beautiful scanning electron micrograph, isn't it, of asbestos fibers. And you can see that the fibers are long and thin, and it's thought that they may have an aerodynamic action that promotes their movement far into the lung, a bit like a paper model airplane that you throw and it penetrates to the other side of the room. Maybe asbestos fibers do that. Once they get into the lung, they generate a pretty fierce reaction, and you can see the asbestos material here, and this red ferruginous asbestos body, it's what it's called, and these can be actually coughed up in the sputum, and you can actually see these asbestos bodies in the sputum. Now there are 3 different asbestos-related diseases. The first one is diffuse interstitial fibrosis, again very like the diseases that we talked about in the session on restrictive disease. It's one of the causes of diffuse interstitial fibrosis. These patients are also more likely to develop bronchial carcinoma. I'm not going to say that much about that at the moment. We're going to talk a little bit about bronchial cancer a bit later on. And the third thing is a pleural disease, including malignant mesothelioma. So let's look at diffuse interstitial fibrosis, which is sometimes called asbestosis. Asbestos is a fibrous mineral silicate, and it's used extensively, or was used extensively, in industrial applications, lagging of pipes. It's used in homes, for example. I'm sure you're aware of old buildings where they're doing some repairs and they find that there's asbestos there, and there's a terrible problem getting rid of the asbestos. So it was very extensively used. Shipbuilding, for example, was used, brake linings, used a lot. And it turns out that the disease tends to occur after fairly heavy exposure. As other forms of diffuse interstitial fibrosis are seen, there's progressive dyspnea on exercise. You often get finger clubbing. You get these fine crepitations or crackles by auscultation, and as far as I know, the reason for that is not fully understood. There's no fluid in the lung, but the fibrosis causes these fine crepitations for some reason. Lung function shows the typical restrictive pattern that we talked about extensively in the session on restrictive disease. There's reduced lung volumes, the compliance is reduced, and the diffusing capacity is reduced. So these are all typical findings of diffuse interstitial pulmonary fibrosis, caused in this case by asbestos. Now let's turn to the pleural disease, and it's a very remarkable condition, this. For example, it can occur after very trivial exposure, and there are a number of anecdotal accounts, for example, of the wives of workers simply washing the clothes of the workers and then later on developing pleural disease, the wives developing pleural disease, even though all they've done is wash the shirts or whatever of the people who are working with asbestosis. It's quite frequently you get some pleural thickening, which you can see on the radiograph, and plaques, but they're usually harmless. But you can develop what's called a malignant mesothelioma, cancer of the, or neoplasm of the mesothelium lining the lung, the pleura, and that can develop long after exposure. Many, many years after exposure, you can develop this mesothelioma. The result of that, that's a very nasty disease. You get restrictive chest movements, severe chest pain, and a rapid downhill course. And there's a lot of interest at the present time in trying to detect patients who've developed malignant mesotheliomas. There's a lot of work done by lawyers trying to help people who've got this. So it's a serious problem. Asbestos is one of those areas of industrial medicine which has changed over the last number of years and is responsible for a tremendous amount of litigation. Now let's just say a word or two about other pneumoconioses. Iron and its oxides cause a thing called siderosis that I'm not going to talk about in detail, except to say that it's got a very striking radiological appearance. The radiograph shows these very, very black marks on it because the iron absorbs the X-rays, of course, and so you get this tremendous markings on the X-ray. I say black. With the normal radiograph, they show up as white, but I mean they absorb the X-rays, of course. Antimony and tin can cause pneumoconioses, and one I should mention is beryllium. Now that used to be used in fluorescent bulbs a lot, and it can cause a severe restrictive fibrosis of the lung. Fortunately, it's not, and that's called berylliosis. Fortunately, we don't see that nearly as much now because fluorescent bulbs don't use that in them, and but that at one stage that was a very serious problem, and the cause was these fluorescent bulbs. Now I'm going to talk about Bissonosis. That's caused by it occurs in the cotton industry, and first I should say that technically this is not actually a pneumoconiosis. Pneumoconiosis is usually limited to non-organic materials. We've been talking about coal and silica and beryllium and so on. But Bissonosis is caused by an organic material, and it's actually the bracts surrounding the cotton ball. Here's a beautiful photograph of a cotton ball here, and these are the bracts around the cotton ball, and they are apparently responsible for the disease. It's an airway disease. The exact mechanism, I'm not sure it's fully understood. A lot of people think that it affects the mast cells that release histamine, and that causes bronchoconstriction. It's an interesting disease because the symptoms are worse after a period of absence from the mill, the cotton mill. And for that reason, it's often called by the people who work in the mill Monday fever. And that's because even over the weekend, that's a short period of absence from exposure, but then when you're re-exposed on the Monday, you get the symptoms of Bissonosis. Fever is a misnomer. There's no increase in temperature, but it refers to the symptoms that people see on a Monday. It's typical changes with airway obstruction. You get dyspnea, a sense of tightness of the chest, wheezing and cough. And pulmonary function tests show an obstructive pattern. The symptoms actually lessen during the working day. During the Monday and then Tuesday and Wednesday, the symptoms will be less, but then when you take a break on the Saturday and Sunday, you come back on Monday, then the symptoms occur again. Chest radiograph is essentially normal. A very long exposure can result in something like COPD, but of course in the industry now people are protected by proper ventilation, perhaps by using respirators. People tend to reduce the amount of Bissonosis. Another condition that we'll mention is occupational asthma. Again, not a pneumoconiosis. It's caused mainly by organic materials, allergenic dusts, and there are a number of these. In flour mills, for example, people are sensitive to the wheat weevil. in the flower, and they develop occupational asthma. It's rather like asthma, but the allergen is the material in the workplace. Printers exposed to gum acacia can get it, or people who are working with fur or feathers can develop this. There's an interesting form used in the industry making polyurethane products, plastic materials, where toluene diisocyanate, TDI, is used, and some workers develop a tremendous sensitivity to this. In fact, in many cases, workers develop such a sensitivity that they have to change their job because they can't work with this material. So that's occupational asthma. Now I'm going to say a little bit about bronchial carcinoma, and again, let me repeat what I said right at the beginning. I'm going to talk a little bit about neoplasms and a little bit about infectious disease, but I want to emphasize that these really are not important in the area of pulmonary pathophysiology, which is what we're really talking about. Pathophysiology is an abnormal function of the lung, and the use of pulmonary function tests to show that bronchial carcinoma, the changes in function of the lung and the use of pulmonary function tests are really not important at all. But of course, bronchial carcinoma is a very important disease, as we'll see here. Look at the cancer death rates from 1930 to 2004. Now, I don't know if you can easily read these, but this is stomach cancer here, which happily has declined. I don't know why. And other diseases, colon and so on, prostate cancer up here, pancreas and so on. But look at lung cancer. Tremendous increase. And that's because of the increase in smoking during World War II. There was a big increase in smoking, particularly in women who worked in factories in World War II. And of course, the cancer shows up a number of years later. So that's the reason. Happily, it looks as though there's a bit of a decline here. Well, substantial decline. And that, I hope, is caused by the increased knowledge of the dangers of smoking, and also very big programs trying to prevent people, trying to persuade people not to smoke cigarettes, and also the increasing cost of cigarettes as well. So let's look at the classification of lung cancer, and I'm going to do that rather briefly. They're classified into small cell carcinoma and non-small cell carcinoma. And small cell carcinomas show a homogeneous population of these cells. They're often thought to look like oat cells. Highly malignant, and makes up about a third of all cancers. And here's an example, a very nice slide showing small cell carcinoma, and you can see a rather uniform appearance of these oat cell-like cells here. The non-small cell carcinomas are of three types. First, the squamous carcinomas, then the large cell carcinomas, and the adenocarcinomas. Now, the squamous cell carcinomas are relatively common, nearly half the cases, and they sometimes show a whorl pattern, and you can see that here. Here's an example of a squamous cell carcinoma, and you can see a couple of whorls here, one here, another one over here. They're characteristic. The next category of the non-small cell carcinomas is large cell carcinomas. You don't see the whorls, and they are not uncommon, tend to occur in the periphery. And here's a nice slide of a large cell carcinoma. And then finally, in the non-small cell carcinomas, we have the adenocarcinomas, which often produce mucus. They tend to be commonest in women. And here's a nice slide showing the mucus production of this adenocarcinoma here. Now, the clinical features of bronchial carcinoma, we won't dwell on them because, frankly, they're not terribly important. Well, I say they're important if you can use them to pick up the disease. A patient who develops a cough, well, I mean, lots of people have a bit of a cough, so that's difficult. Hemoptysis is a particularly important sign. If a patient in his 50s or 60s suddenly develops hemoptysis, that's a very suspicious sign, and Carcinoma is certainly one of the important causes of that. Later on, patients may develop hoarseness because of damage to the left recurrent laryngeal nerve. They may develop a pleural effusion or bronchial obstruction, chest pain due to pleural invasion. Now, when these things occur, unfortunately, it's far too late to do much about the carcinoma generally. So when I say the clinical features are not important, what I meant was that these more florid forms are not important, because basically in bronchial carcinoma, what you want to do is make the diagnosis early so that the carcinoma can be removed or radiated or whatever. But for example, lung function tests are of essentially no value in diagnosis, because in advanced carcinoma, there's changes in lung function, of course, but that's far too late to do anything useful. The only place where they are useful is in sometimes pre-operatively, because some patients with carcinoma of the lung you can remove the lobe of the lung, but often these patients are smokers, usually, and they often have some COPD as well. And the question is, will they survive the surgery, and will their lifestyle, quality of life be useful after the surgery? So lung function tests are sometimes useful in the preoperative evaluation prior to surgery. Now, a few words about infectious diseases. Again, extremely important in the context of pulmonary medicine, but relatively unimportant in the context of pathophysiology. Pneumonia, a very important disease, of course, particularly in older people. Pneumonia is one of the reasons why older people, they often have a terminal pneumonia. It's an inflammation of the lung parenchyma, and it's characterized by filling of the alveoli with exudate. In fact, the alveoli are crammed with cells, chiefly polymorphonuclear leukocytes. The patient will usually have a fever, will have malaise, will feel off color, have a cough, and may have pleuritic pain. And the radiograph is usually diagnostic. Pulmonary function tests are not important here. But the radiograph is diagnostic. The patient often will have hypoxemia, and here's a nice radiograph showing pneumonia in the mid-zone base of the left lung here. Now, pulmonary function in pneumonia won't delay us for long. The pneumonic region is usually unventilated because the alveoli are crammed full of exudate and cells. If it's perfused, of course, you get hypoxemia. That's an example of shunt, the extreme of the ventilation-perfusion ratio spectrum, if you like. The blood flow may be reduced in the pneumonic area, probably is, either by the disease process or by hypoxic vasoconstriction. Normally, you don't get CO2 retention in pneumonia. Sometimes the breathing movements are restricted by pleural pain or by pleural effusion. But in general, pulmonary function tests are not useful in the management of people with pneumonia. I should say something about tuberculosis, because historically, of course, it's been a devastating disease over the centuries. Captain of the men of deaths, it was called, I think, at one stage. But now, happily, in well-developed countries, it's now mostly controlled with antibiotics. On the other hand, it's still a serious problem in underdeveloped countries. Can be a really serious problem in poor countries. Another problem is that resistance to antibiotics has developed, and this can be a major problem, because some of the cases, the usual antibiotics are of no value, and that's a very serious problem. The initial infection is of the lymph glands, and it's in the lung, high lymph glands, and is not recognized almost always. But the post-primary infection, the infection in the adult, usually occurs at the apex of the lung, and that's of interest to pathophysiologists, because we believe that the reason why the adult tuberculosis prefers the apex of the lung is the fact that the ventilation perfusion ratio is high there and the PO2 is high there. And you can show that the tubercle bacillus thrives better at a high PO2 than a low PO2. Usually the infection these days is controlled with antibiotics. However, in the good old days, it would extend to give miliary infection. Incidentally, I can remember when I was a medical resident that we did not have proper antibiotics. And I can remember doing unilateral lung collapse, pneumothorax for tuberculosis. So that was a very long time ago. Things have changed a lot. But in the good old days, there used to be miliary infection from the initial infection. Cavitation very frequently occurred, and all sorts of terrible operations were developed to reduce the volume of the chest cage. You could get pneumonia, pleural effusion, and patients who had old, long-standing tuberculosis would often develop very severe fibrosis and very strange changes on their chest radiograph. Another group of patients who are at risk these days are immune-compromised patients, for example with AIDS, because they may develop tuberculosis. Let's a word or two about bronchiectasis. We don't see so much bronchiectasis these days, but again, when I was a medical resident, we certainly saw bronchiectasis. It's characterized by dilatation of the bronchi with suppuration. And when I see dilatation of the bronchi, I'm reminded of the definition of emphysema, which is a dilatation of the lung distal to the terminal bronchi, so of the terminal bronchioles. So here we have dilatation proximal to the terminal bronchioles, usually in the large airways. It often followed childhood infections, childhood pneumonia. And the reason why we don't see it so much now is because of the effectiveness of antibiotics. Children are treated so much better. But if you do get bronchiectasis, which you don't often see now, the patient has a productive cough with yellow or green sputum. It's a very unpleasant disease, and there's often extreme halitosis. Finger clubbing is common, and there are radiological changes. You can see the changes in the diseased airways. The loss of function is not particularly important, but in chronic inflammation, you can get fibrosis. Here's a lung with dilated bronchi from bronchiectasis. We can see the dilated bronchi, which of course are very abnormal, caused by bronchiectasis. And the final condition I'm just going to mention briefly is cystic fibrosis. Again, a very important disease, no question about that, but in the context of pulmonary pathophysiology, not so important, simply because pulmonary function tests are not particularly useful, certainly not useful in the diagnosis, and not really useful particularly in the in the management of these patients. It's a disease of all exocrine glands, and the principal organ affected is actually the pancreas. It's caused by a mutation of a gene, the CTFR gene, which affects chloride and sodium transport across cell walls. A lot of people have the mutation, but you need 2 copies of the defective gene before you get clinical cystic fibrosis. In the lung, you have excessive secretions from these hypertrophied mucous glands, so it's a little bit in that respect like chronic bronchitis, but cystic fibrosis occurs in young people. It often comes on after 1 or 2 years of life. People become aware of the fact that there's cystic fibrosis. You get plugging of small airways, you get chronic infection, productive cough, frequent chest infections, decreased exercise tolerance, finger clubbing, and radiological changes. Now, the sweat test is diagnostic, and these patients now are usually diagnosed as a relatively early age. But unfortunately, there's not all that much you can do about it. You can control the infections with antibiotics. You can use, you can help the patient to get rid of retained secretions Physiotherapists can help with that. But it used to be that most of these patients died before they reached the age of 20, but now many of them survive into their 30s, for example, perhaps even longer, and that's because of the improvements in management. You would hope, and everybody has, that now that the gene has been identified and a good deal is known about the genetic change, that there would be an effective gene therapy, but regrettably that has not happened as yet, but hopefully in the not too distant future we will see that happening. So that's all I'm going to be saying about these environmental and other diseases. Environmental disease is extremely important in terms of prevention. The other diseases, neoplastic and infectious diseases, desperately important in terms of pulmonary medicine generally, but not particularly relevant to pulmonary pathophysiology. And so I'll leave that there and look forward to seeing you next time.